Physiology of inflammation.
Redness, swelling.
That's a symptom.
You can see it.
That's a symptom. Give me the pathophysiology.
Tissue injury.
That's the cause. Pathophysiology.
The body's trying to heal it.
Well, that's pretty general. Thank you very much for that input, though.
Megan will say you wait. He said no, he's right. Because
Hey, I've got a hard enough time speaking the way it is. I don't need all the competition. I really don't. I'm getting too old for this. Well, yes and no. That's be ill. Well, let's move right on into it, and then we can do that. Keep that right back there for a minute. So how was your day? The guy on the truck's gonna have no trouble whatsoever. Some people can happen. All this stuff here, if you were to consolidate or summarize the entire thing, you have injury, which causes chemical mediated, which causes blood vessel dilation. So we have fluid and white blood cells and so forth rushing to the area to protect the body, as we heard over here. Causing the swelling. That's the body's way to protect whatever is injured by putting a natural cast on it.
I have to find it.
And then all the other chemical components are there in order to maintain that process so that all the things that the body needs, the excess blood and so forth, so the body can heal itself. The only problem is some of these things can cause issues like pain. Why is pain important?
it hurts.
Did you know that there's something wrong?
Exactly. It tells you that you got a boo-boo. If you didn't have pain, you wouldn't know that. And then you continue to hurt it over and over again. But what happens is some of these things are the body's own worst enemy. It protects it, but at the same time, the cycle it causes can actually cause more harm to the body itself. So, we could create drugs in order to help slow or prevent some of these chemical reactions and so forth, so that, yeah, the body can help itself, but then we can help it through chemistry. So, somebody was telling me the cardinal signs of inflammation. What are they?
Redness.
Redness, swelling, heat, pain. Any others?
Loss of function.
Loss of function. If you ever got a sprained ankle or something like that, you know right away that these things occur, and you have loss of function in an area because of the swelling and the tenderness and so forth.
Thank you, I need it.
So we have images of the inflammatory response. You had these on your PowerPoint, right?
Mm-hmm. Yes.
We have a inflamed throat, elbow, politics, anti-inflammatory drugs. We have these enzymes which take place. And what happens is that these enzymes form these two basic ones, coenzyme 1 and 2. You can see what it does. One is a wonderful thing. It kind of protects the body, doesn't it?
Mm-hmm.
Number 2 is what causes all the problem. That's what opens up the blood vessels, causes the inflammation, and causes the nerves to become sensitive, and you have more pain. So the medication we have, most of your anti-inflammatories, which one of these do you think they're going to affect?
2.
COX-2, because we're trying to prevent the pain and the inflammation and so forth that goes along with that injury or whatever, right? The stomach lining was a second thought. That didn't come right away. Somebody thought of that later on. So the drugs that we have, basically we have NSAIDs, non-steroidal anti-inflammatory drugs. Steroids, we have disease-modifying anti-rheumatic and anti-gout drugs. All of these fall under anti-inflammatory, although some of them work in specific areas. The NSAIDs work with the prostaglandins and cause these effects. We have an analgesic effect, which is what? Pain. And antipyretic. Inhibit platelet aggregation. Okay, preventing blood clotting, right? Mimic the effect of the steroids in reducing swelling and contraindication during times of active bleeding, i.e. menstruation, because of some of the effects. The use of the medication has to be judged. Is it going to be useful or harmful given any particular situation? Any medication works the same way. So NSAID, it inhibits the COX enzyme, primarily 2. How do we know this?
Does the pain goes away?
It does, and the swelling comes down somewhat. And what's the other thing that we have associated with this? GI distress. So we know it does not affect the COX-1 or the COX-1. Does not affect it whatsoever. But it's reducing all the other things. Reducing inflammation, pain. So that here, primary medication for rheumatoid and osteoarthritis. What's the difference? Well, they both have to do with joints, don't they? Rheumatoid is a autoimmune issue. It attacks the joint. And osteoarthritis is an overuse issue. Anybody over the age of 35 has osteoarthritis. And as you get further and further past 35, it becomes more and more painful. Not recommended fever or headache, aspirin, ibuprofen. Generally because of the actions that they have. We'll go into more of that. Side effect, the major one, gastrointestinal discomfort. Not only does it cause your tummy to hurt, but if you continue to take it on its own without any food, it'll also give you an ulcer. This is one of those medications. The doctor says, okay, if you're going to take it 3 times a day, you better take it with breakfast, lunch, and supper so that you have that food in your stomach to be able to cushion it. So some of our first generation NSAIDs, as you can see up there, we have the things like Motrin and Advil and so forth fall within those categories. Second generation NSAIDs, the COX-2 inhibitors. What does the COX-2, well, the COX-2 inhibitor, we know what it does, right? the inflammation pain. Second generation NSAIDs also limit COX-1, which does what? It protects the stomach, okay? When they came out with Celebrex, it was the greatest in the world because you can take it on an empty stomach and not have the gastric issues that you did as you give ibuprofen, and still get similar relief. Aspirin, made back in the 1880s, wonder drug of the century. Does all these things. The therapeutic level, that is for your own information. I'm not going to ask you what that is. But it becomes toxic if we have more than 30. Does anyone know what the symptom of toxicity of aspirin is? Tinnitus, ringing in the ears. Ringing in the ears.
GI upset. GI distress.
Oh, you have that, yeah. If you have too much, your tummy's gonna hurt, yes, it really is. The drug itself, we know that is an antiplatelet aggregate, so it's going to cause bleeding. You have increased bleeding when you use it with anticoagulants. Hypoglycemia with oral anti-diabetics. So if we have hypoglycemia with oral anti-diabetic medication, what does that tell you? What does this mean?
Low sugar. Low sugar.
Okay, low blood sugar. So these medications tend to take or help the body to take the blood or the sugar out of the blood and get it to the cells, correct? So if we have hypoglycemia, what is that telling you? Last blood sugar. So what does that tell you? No, it increases the effectiveness. Okay.
The medication.
But what happens when we have hypoglycemia, the medication and the body is actually taking more sugar out of the blood than it should and putting it within the body itself, either using it or, you know, if you remember all that stuff, it stores to the glycogen, et cetera, right? So it actually enhances the oral anti-diabetic, something that has to be noted. Increased ulcer risk with any steroid, because steroids themselves have a caustic effect on the stomach, the same as a NSAID does. Increased PT, which is what? Who knows that? Prothrombin time, what's that do? Okay, how much bleeding, exactly. INR.
International normalized ratio.
Right, which is measuring what? It is. Years ago, we used to do PT and PTT, APT, and then they went down to switch it over to INR. It makes it easier to write. That's all I think. We also have to look at things like cholesterol, T3, T4. We know that it may affect the thyroid, T3 and T4. So are the components of your thyroid stuff. My mind just went blank. Thyroid stuff. Lab, decreased potassium, which means that this medication also affects that within the blood. Cholesterol. And then foods containing salicylates are the ones that you see there, which is interesting because in years gone past, someone had a sour stomach, somebody had a headache, somebody wasn't feeling very well. You know what they did for them? Gave them licorice. That cured everything. Black licorice. They hadn't invented red stuff yet.
They say dried cherries are supposed to have analgesic properties.
Oh, there's lots of foods that have analgesic properties. Enough Jack Daniels has analgesic properties.
I just learned that.
But in toxic amounts, it causes the opposite effect. There are a lot of foods that they don't necessarily have glycolate in them, but they have other ingredients that assist the body in that kind of recovery. Aspirin costs do not take with other NSAIDs. Why? Okay, constant effect, you're increasing the effect of the medication, aren't you? Avoid during third trimester of pregnancy. Why? Hemorrhage. Exactly. Do not give the kids with flu or virus because of Rice syndrome. That's been known for quite a few years now. So, and the side effects that we already have listed. What is thrombocytopenia? See that? I've heard a whole bunch of different things.
Decreased levels of thrombocytes.
Okay, which causes what? Pardon?
Bleeding?
Bleeding, thank you, yes.
So it's bleeding.
The major symptom of thrombocytopenia is what's called petechiae, or little spots red all over, which is caused by rupturing capillaries, or the bleeding through that. We have leukopenia and agranulocytosis. We are having some issues or some minor blood dyscrasias going on as we have with some of the other medications. And we have hepatotoxicity. What does that tell you? It's metabolized in the liver. It is broken down to be excreted. Okay, so it does affect the liver. Say what?
Really bad way to try and commit suicide because it takes a really long time.
It takes a very long time, yes. It does.
Generally, they save you when you don't have a liver. Pass that on to your.
Well, I guess that's, you can do that if you're not really serious. I'm not quite sure you want to go that direction, you can just take that, and then if you have to stop, you can, right?
Right.
There you go. So let's hypersensitivity, you're going to have some of the adverse reactions you normally would. And then we have some of the severe poisonings that you can see, convulsions, cardiovascular collapse, and coma. And that again is a reminder that the body systems do not work in a vacuum. Your joints and your bones aren't separate from your nerve systems and your brain and so forth, because they are all innervated. They each are attached to one another. And you affect one system, you affect another system. We're talking about affecting enzymes and so forth. It's just not blocking enzymes, it's affecting the nervous system, so that enzymes and so forth are now decreased and not being produced as much. Well, the body system as a whole is being affected, not just the bone itself. Yes, ma'am? Oh, the 30 milligrams diluted. Oh, for milligrams? Right, 325. The recommended dose is 1,000 milligrams per dose. Is maximum. About 3,000 a day is maximum. Now, can you raise or lower that? It can be. For example, ibuprofen, the recommended dose, ibuprofen is 1,800 a day. Is recommended. However, the body can handle 3,600 per dose.
I was gonna say the Air Force, they hand out Motrin 800s like they are called the vitamin for the military, and they won't give you.
Yes, it is the wonder drug of the century, it is.
Sure is. A wonder drug.
We'll get into that some more, but the dosages vary, and it varies on how the person responds to it. The thing to remember is when you're giving medication, it's all based on individual. That I can handle a large amount of ibuprofen to where maybe you can't, based on the body system. And it's based on how they respond, what side effects do they have, what kind of reaction do they have. And it goes back to my first lecture is, you know, when you talk about early in medicine, okay, you feel sick, eat this fruit. She died, okay, you're sick, don't eat so much. Go along the same lines where the recommended dosages, and then they are again regulated based on the individual, how much they can or can't handle. Oh, we have another NSAID, propionic acid derivatives. Ibuprofen, Motrin, Advil. Any other new names out there?
What's Excedrin?
Aspirin. Aspirin with a little kicker. Excuse me.
Or with caffeine, right?
Well, sort of, yes, there is caffeine. But ibuprofen, Motrin, and Advil, the main component is ibuprofen. They have a little bit different additives that they'll put into it to enhance the ibuprofen. But it's basically the same thing. It is a non-selective COX inhibitor, although it primarily affects COX-2, which is what? Inflammation and pain, correct. So drug interactions, like any other NSAID we see up there, increased bleeding with warfarin, which is known as Coumadin, which is an anticoagulant. Increased the effects of phenytoin, I can never pronounce that correctly, phenytoin, which is a psychotropic medication or anti-seizure medication. It's decreased effects with aspirin, which is interesting is that we have ibuprofen, which is an NSAID, aspirin, which is an NSAID. However, if you take it with aspirin, yet you're going to have bleeding issues and whatever else, but the aspirin tends to take over the receptor sites and leaves the ibuprofen kind of wander around and become a mess. Okay? That's why on the package or Motrin it says do not take with aspirin. Okay, number one, it decreases effect. Number two, it increases use like gastric distress. It can increase this, but it increases bleeding, which is the most dangerous. Questions so far?
When the doctors prescribe, do they use it for synergistic effect? Like, do they prescribe?
No. No, this has,
Like Dilantin?
no. They won't use it for that at all. They won't say, okay, we're going to use it for this in order to increase that. But what they realize, though, is that you do have the increase with this, so that they will, if they're having this and they decrease this in order to prevent having this reaction, or they may decrease this for the time that they have the injury, and just kind of watch for symptoms and so forth and vary accordingly. Or in some cases, they just watch. Okay, you start having issues with seizures or tremors, whatever else, well then the ibuprofen goes away and something else comes in. Okay, because this is the more important medication to have on site, which is more long-term than this one is. Does that make sense? Other ones we have, Nactisen, Daypro. The interesting thing with these ones are they are very strong COX-2 inhibitors. However, they are very strong. They hurt the tummy even more than the other ones. They have worser side effects than ibuprofen. Yes, they have worser side effects. We mentioned Celebrex already. We have Rolofen, we have Mobit. That they are selectively inhibit the COX-2 so that we have the decreased inflammation and pain, but they do not inhibit COX-1, so we have less stomach issues. We have less stomach issues. Where the other ones inhibited COX-2, but they also non-selectively went down and inhibited COX-1. Kind of fallout. So rather than protecting the stomach, they took that away. So that's why you get your gastric upset. And Celebrex, not only is it having a less gastric irritation, a smaller dose of Celebrex actually has the same effect as a higher dose of ibuprofen. Being second generation and being more modern.
So the other two agents do the same thing? as
Yes.
Celebrex?
Yes, they do.
Is this sold like at pharmacy drugstore, the Celebrex? So what prescription?
That's all prescription.
Oh.
Who knows? One day it may not be. I mean, things like Benadryl or what. Ibuprofen was prescription only for a while, and Benadryl, and now you find them all. It will, yeah. It'll take a few years. Indocin or endomethacin is a non-selective inhibitor of COX-1, COX-2. Remember we talked earlier on about protein-bound medication? These are highly protein-bound, which means that they can stay in and they have a longer acting effect. And they're used because of that. You don't have to repeat the dose quite often. The only other problem is that non-selective inhibitor of COX-1, these cause severe stomach pain and ulcers. That's the worst side effect. They're really good otherwise.
Does it also mean when they're highly protein bound that it also takes a while for clinical response to kick in, or is it just has a long?
Well, what happens is it has a longer life. And not all the medication will be bound to the protein. Some of it still remains free, but the majority of it stays bound up. And then eventually the body, the plasma protein release it, and then it goes into the bloodstream and then gets out where it needs to. So it tends to last longer than some of the other medications, but the side effects are more severe than some of the other medications. Does that make sense?
Would it take longer to reach its peak therapeutic?
Yes.
So is that just endomethacin?
Correct. Correct. Indocin. Not just that. Question? Again, like with the first generation, we want to watch for pregnancy, side effects. We have some of the similar side effects. The couple that we have differently, we have sinusitis, inflammation of the sinuses, have headache, and we have a tendency of peripheral edema. So we have some issues of how do you say, decrease and increased circulation at the same time. We'll be covering more of that when we get into cardiovascular. Just understand that that's what that is. Infants and older adults, we know that as you're younger, as you're older, your body can't handle a lot of stuff.